Shall I start, sir?
Yeah. Please start, Dr. Vimal.
Okay. So good evening all. So we'll resume from the questions from where we have left yesterday. So the 20th question today we'll be starting with is the Hennasch-Scholing purpura is characterized by the deposition of the following immunoglobulin around the vessels. So the options are IgM, IgG, IgA and IgE. Let us see another question. Hypersensitivity angiitis is seen in systemic lupus erythematosus, polyarthritis nodosa, Hennasch-Scholing purpura, Buerger's disease. So for solving these two questions, we have to know about Hennasch-Scholing purpura. Hennasch-Scholing purpura is otherwise called as anaphylactoid purpura. So it is nothing but it is a neutrophilic vasculitis of small vessels with the deposition of IgA in the wall of involved vessels. So what happens here? It is a vasculitis, that is inflammation of the vessels, and neutrophilic vasculitis, that is the inflammation is predominantly the infiltrate is of neutrophils, and it is characterized by the deposition of immunoglobulin A around the involved vessels. Clinically, the patient presents with a tetrad of features. This is called as the tetrad of features like purpura, skin rashes, and arthritis, joint involvement, glomerulonephritis, and abdominal pain. These are the four main clinical features with which these patients with Hennasch-Scholing purpura presents. And usually with this glomerulonephritis, there will be a preceding history of a respiratory infection, like sore throat infection or this thing. So preceding infection history will be there, and the patient will be then presenting with a feature of hematuria, and if you clinically, it will be a tetrad. So what happens, what causes these neutrophils to be infiltrate around the small vessels? It is mainly the Th17, that is a T helper 17 cells. These cells are activated and they recruit the neutrophils to the site of injury. So what happens with the when because of these cells, they are recruiting the neutrophils. More neutrophils will be deposited around the vessel walls. Okay. So basically, remember it is a IgA deposition and it is a T helper 17 cells which recruits the neutrophils. And remember the clinical 4 tetrad features. Okay. So Hennasch-Collin purpura, otherwise called as anaphylactoid purpura. And also the patient will be, because it is an immunological event, no, so patient will be having, actually, in spite of thrombocytopenia, the patient will be having thrombocytosis. Okay, this is the essential clinch we have to remember. There is no thrombocytopenia. Instead, there is thrombocytosis, that is the elevation in the platelets, is seen in Hennasch-Collin purpura. And the complement levels are normal, and HLA levels, actually HLA, which HLA is involved in HSP, that is Hennasch-Collin purpura, has been asked twice in your previous exams. Okay, so HLA-B5 and HLA-B5-1 association is commonly seen in this Hennasch-Collin purpura. So with this background, let us solve this question. Hennasch-Collin purpura is characterized by deposition of the following immunoglobulin around the vessels. Yes, by this time you will be knowing that it is IgA, that is immunoglobulin A. Yes. And also the other name for this Hennasch-Collin purpura is the hypersensitivity angiitis. Hypersensitivity. Okay, so it is an hypersensitivity reactions. Okay, because of an immunological damage is happening here. Exaggerated immune response is happening here, and it mainly involves the vessel. So it is called as hypersensitivity angiitis. So you have 3 names for your Hennasch-Collin purpura: Hennasch-Collin purpura, hypersensitivity angiitis, and anaphylactoid purpura. Yes. So now let us solve this clinical question. A patient presents with respiratory symptoms. That is, a patient is having cough, hemoptysis, glomerulonephritis. His C anchor levels in serum were found to be raised. The most likely diagnosis is. So if you carefully analyze these clinical symptoms, you are given the 4 options for this clinical symptom, that is Goodpasture syndrome, classic polyarteritis nodosa, Kawasaki syndrome, Wegeners granulomatosis. Yes. What are the symptoms of the patient? Patient is presenting with the respiratory symptoms. So cough, hemoptysis will be there, and also glomerulonephritis. Yes, so the patient level, the patient clinical syndrome actually deals with the 2 systems, that is respiratory system and the renal system. So we have to, among these options, we have to choose which one is fitting in this thing. Okay, so actually this Goodpasture syndrome and Wegeners granulomatosis is both having, like, can have respiratory symptoms and glomerulonephritis features. Okay, so but these 2 options are thus ruled out, that is polyarteritis nodosa and the Kawasaki syndrome. Okay, so if you further explore, the one more clue has been given by the exam paper setter, that is C ANCA levels in the serum were found to be raised. Okay, yesterday we have seen that what is ANCA. Okay, that is a anti-neutrophilic cytoplasmic antibodies. Okay, these are in the cytoplasm and against the neutrophilic granules. Okay, it is a C anchor. Okay, cytoplasmic anchor. So it is found to be raised. But if you attended the yesterday's class, you will be remembering that anchor positivity is usually seen in Wegeners granulomatosis. So Wegeners granulomatosis, yesterday I told you the reason name for Wegeners granulomatosis, that is the for granulomatosis with polyangiitis. Yes, with the granulomatosis, granuloma, with the polyangiitis, that is involvement of the multiple vessels will be there. Goodpasture syndrome. Let us see something about Goodpasture syndrome. Goodpasture syndrome is actually the patient, it is the antibodies will be presented against the basement membrane, glomerular basement membrane. Okay, so what happens in Goodpasture syndrome? The patient will be having antibodies against the glomerular basement membrane. As you know, that glomerular basement membrane is the actually the filtering unit. Okay, that is the filtration barrier. If the antibodies are formed against this thing, the basement membrane getting damaged, and the patient will be presenting with features of glomerulonephritis, mainly with hematuria. Okay, mainly with the hematuria. And also the patient will be presenting with the respiratory symptom, that is hemoptysis, because of the sharing of the antigens between a alveolar capillary membrane and the glomerular capillary membrane. The patient presents with hematuria and hemoptysis. Okay, so both these symptoms can be seen both in Goodpasture and Wegeners. But why we are answering here Wegeners means, preferring Wegeners means C ANCA levels are usually elevated in Wegeners. Yes. So as I said, the Wegeners, the recent name is granulomatosis with polyangitis, and it is characterized by three important features that you call it as a triad. So the triad of Wegeners granulomatosis include mainly the necrotizing granulomas of the upper and lower respiratory tract. Okay, so the patient can have granulomas both in the upper as well as in the lower respiratory tract. Okay, the patient can have granulomas in the nasal cavity. Okay, and in the aerative tract. Okay, upper respiratory tract also, and even in the lungs also necrotizing granulomas, and also necrotizing granulomatous vasculitis. Okay, the patient may be having vasculitis. So that in the vessels also you can get granulomas. And the third feature will be focal proliferative crescentic glomerulonephritis. I said you yesterday that actually now also I said both renal involvement also will be there in Wegeners. So what the patient will have? The patient will be getting focal proliferative. Okay, there will be a proliferation of the kidney cells, that is the epithelial cells, crescentic, okay, in the form of a crescentic glomerulonephritis. What is the other name for crescentic glomerulonephritis? Any idea? It is called as RPGN. RPGN. Remember, when we'll be dealing with renal chapters, we'll be studying all these things. So RPGN is rapidly proliferative glomerulonephritis. Rapidly proliferating glomerulonephritis. Okay, so that is the other name for crescentic glomerulonephritis. So dear students, please remember, you have to remember the three clinical features in Wegeners. That is, granulomas can be seen, that is the necrotizing granulomas can be seen both in the upper and in the lower respiratory tract, and also the granulomas may be seen in the necrotizing granulomas may be seen in the vessels, around the vessels, and in the kidney you have the crescentic glomerulonephritis, that is a rapidly proliferating glomerulonephritis. And you know by this time that is C ANCA positivity will be there in more than 75% of the cases, and only 25% of the cases will show P ANCA. And because of the respiratory tract involvements, what are all the features the patient can present with? Patient can present with persistent pneumonitis, okay, involvement of the lung parenchyma with bilateral nodular and cavitary infiltrates. This terminologies, please mark it down. Nodular, actually the lung involvement will be in the form of a nodules. Okay, so it will be in the form of a small nodules, and the cavity formation will be there. Okay, so you can see from this picture, the lung is involved here, okay, in the form of a nodules, and you can see a cavity formation. Why there is cavity? Because there is a necrosis happening here. Okay, so necrotizing involvement. Okay, so I told you that it will be necrosis. So after the necrosis, what happens? The tissues dies. Okay, so that material will be expelled off, so you will be getting that cavity formation similar to that of tuberculosis in Wegeners. Okay, so and chronic sinusitis. The patient, I told you, upper and lower respiratory tract will be involved. So the patient will be having chronic sinusitis and mucosal ulcerations of the nasopharynx. Okay, so you can have, because of the upper respiratory tract involvement, you can have granulomas in the upper respiratory and lower respiratory tract in addition to the renal lesions. So what you can see in this picture, you can see a blood vessel. Okay, so you can see a blood vessel, and around these blood vessels, you can see all these blue cells, which are all the inflammatory cells, and you can see a granuloma here, the accumulation of histiocytes. And what is the cell which my arrow is pointing? My arrow is pointing at a giant cell. Okay, so basically it is a picture of a vasculitis, that is inflammation of the vessels with the necrotizing lesions, and a giant cell indicating it is a granuloma. So coming to this question, you know the answer is Wegeners granulomatosis. Which of the following is a non-granulomatous arthritis? So yesterday we have seen many granulomatous arthritis, and today also we have seen that some granulomatous arthritis. Now let us, with this knowledge, let us see whether you are able to solve this question or not. The options they are given is Takayasu arthritis, PAN. PAN stands for polyarthritis nodosa, Wegeners granulomatosis, and Church-Strauss disease. Out of this, the answer is, all of you will be knowing that it is PAN. Yes, polyarthritis nodosa, shortly called as PAN. So it is otherwise called as Kussmaul disease. Yes, polyarthritis nodosa is called as Kussmaul disease, and it is a transmural necrotizing vasculitis. Please remember, here I am saying transmural. Transmural, it is involvement of the all the layers of the blood vessel. Okay, tunica, intima, media, and adventitia. Necrotizing will be there, but there will not be a granuloma. Okay, but there will not be a granuloma. Instead, you will be having the fibrinoid necrosis. Please remember, students, in a blood vessel, the most common type of necrosis you will be getting is the fibrinoid necrosis. That is the deposition of fibrin-like material. So when it is called as fibrinoid necrosis. Okay. The another important points I have jotted out here are the very salient points which have been asked in your previous exams. Okay, so if you have to know these things, you can easily solve the MCQs when it is coming with vasculitis. All the stages of activity may coexist in different vessels or even within the same vessel. Okay, what they actually mean. Okay, all the stages of activity, that is a stage of acute inflammation will be the in acute inflammation, you'll be knowing that mostly you'll be getting neutrophilic infiltrates around the vessels. And sometimes chronic inflammation may be there in the same vessel. You can get lymphocytes. Yes, this is all the different stages of activity. So acute stage, you will be getting neutrophils, and chronic stage, you will be getting lymphocytes. So what they are conveying here? So in these different vessels, you may find the lesions are of different age. That is, in one vessel, it may be of acute inflammatory stage, and other vessel, it may be of chronic inflammatory stage. Further, what they add, even within the same vessel, that is within the same vessel, in one place you will be having the neutrophilic infiltrates, and the other place you will be having the chronic infiltrates like lymphocytes. Yes. So different stages of the lesion activity may be seen in different vessels, or even within the same vessels, you may have different stages of the lesion. Very important point you have to remember in polyarthritis nodosa. The other things you will know is commonly it involves the renal arteries, and very classic point they ask in the MCQs is pulmonary artery is spared. That is, involvement of the pulmonary vessels or very involvement of the pulmonary vessels is very rare in polyarthritis nodosa. Okay, so polyarthritis nodosa spares lung. Okay, very classical point you have to remember for solving your MCQs. Okay, also remember this from your previous MCQs associated with chronic hepatitis B infection. Yes, polyarthritis nodosa is associated with chronic hepatitis B infection. So as I said here, you can see this is the vessel, and in the vessel you can see this pinkish material. Okay, can you appreciate this pinkish material, bright eosinophilic material? This is nothing but the fibrinoid necrosis. Okay, so this is the fibrinoid necrosis, and this is the lumen, and you can see what you can see here. These are all the neutrophils. See this trilobed structure. So the neutrophils are infiltrating the vessel wall. Okay, and also you can see some types of lymphocytes. Also, these mononucleated cells are the lymphocytes. So what I told, different stages of the lesion can be present in a same blood vessel. Okay, so if they show this as an image based question, okay, the patient presents, the biopsy finding presents with these features, what is your diagnosis? So you can see this is a blood vessel with a fibrinoid necrosis, and with you can see the neutrophils and lymphocytes also. So you can come to a diagnosis. Only in polyarthritis nodosa you have different stages of activity. Yes. So it is a non-granulomatous arthritis. Your Takotsubo arthritis, Wegeners granulomatosis, that is granulomatosis with polyangitis, and Church-Strauss syndrome, all will have granulomas. But your polyarthritis nodosa, you will not have granulomas. Instead, you have fibrinoid necrosis. Yes. Now moving on to the other question. Microscopic polyangitis is characterized by the following features, except first option is it affects capillaries, small vessels, and venules. Yes, small vessels is, we already know that it is a small vessel vasculitis. Yes, it involves the skin, mucous membranes, lung, brain, heart, GIT, kidney. They have said about the involvement of the various organs. Let us see the other option. A common presentation is necrotizing glomerulonephritis and pulmonary capillaritis. If you carefully see, In one option itself, they are giving a clue to the solve about the other option. So first here they have said capillaries, small vessels and venules are involved. And here also they are indirectly saying that it is the presentation is necrotizing glomerulonephritis and pulmonary capillaritis is there. Pulmonary capillaritis is there. Okay, so just I am trying to tune your mind to solve the MCQs. Even if you are not knowing, if you are fully exactly about microscopic polyangiitis also, with some background knowledge, and you can able to solve these questions. Even if with one option you can solve this question. So for example, here they have said it is involved small vessels. Here they have said glomerulonephritis and pulmonary capillaritis. So you can come to a conclusion, yeah, capillaries is there and capillaritis. So both these options can be positive. That is seen in microscopic polyangiitis. Okay. Okay. Then the fourth option is palpable cutaneous purpura is rare. Now let us see these things. What is this given here? It involves the skin. Yes, it involves the skin, mucous membrane, lung, brain, heart, GIT, kidney. Yeah, you know that glomerulonephritis, kidney, lung, pulmonary capillaritis. So all these three things, skin. So out of these things, palpable cutaneous purpura is rare, they are mentioned. So you have nothing known about microscopic polyangiitis, but still you can solve the MCQs if you apply the logic here. Okay, that's how you have to approach each MCQ when solving even in a stressful environment. Okay, so now let us see what is microscopic polyangiitis. Microscopic polyangiitis, all of you will be knowing by this time, it is a small vessel vasculitis. Yes, small vessel vasculitis mainly affects the smaller vessels. It is also called as hypersensitivity vasculitis or leukocytoclastic vasculitis. Clinically, they will say it as LCV. LCV stands for leukocytoclastic vasculitis. Yes, hypersensitive vasculitis or leukocytoclastic vasculitis. All the clinical features will be similar to polyarteritis nodosa. And here the interesting finding is P ANCA will be positive. Okay, P ANCA will be positive. Okay, but please remember, though this microscopic polyangiitis is similar to PAN, listen carefully. Microscopic polyangiitis is similar to PAN in all the aspects, but PAN there will not be ANCA positivity. PAN, that is polyarteritis nodosa, will not have any anti-neutrophilic cytoplasmic antibody, but your microscopic polyangiitis will be having the P ANCA positivity. This is a very important point. Okay, expected question which can be asked from microscopic polyangiitis. Yes. And you know this, actually, whenever there is a small vessel involvement, the patient mainly will be presenting with renal symptoms and the alveolar symptoms, okay, lung symptoms. So what happens in renal? Rapidly progressive glomerulonephritis, yes. Also, I told you, crescentic glomerulonephritis, which we saw in Wegeners, no? So also pulmonary capillaritis may lead on to alveolar hemorrhage. Pulmonary capillaritis may lead on to alveolar hemorrhage. So these are the symptoms of microscopic polyangiitis, and what you can see, focal transmural necrotizing vasculitis. So you can see the focal lesions, but see here, very interesting finding. All lesions are of same age. Yes. What does it strike in your mind? I told you in polyarteritis nodosa, all lesions are of different age. But here in your microscopic polyangiitis, all lesions are of same age. Yes. Please remember I told microscopic polyangiitis will be similar to PAN in most of the features, but you have two differences. Yes, but you have two differences. That is, in polyarteritis nodosa, there will not be any ANCA positivity, but in your microscopic polyangiitis, there will be P ANCA positivity. And coming to the nature of the lesions which involved in this polyarteritis nodosa, all lesions may be of different age. And in microscopic polyangiitis, the all lesions are of the same age. Okay, there will not be any granulomas in microscopic polyangiitis. So let us come to this question. Microscopic polyangiitis is characterized by the following features, except you know it affects capillaries, small vessels, and venules. Yes. And also it involves the skin, mucous membrane, lung, brain, heart, GIT, and kidney. And because of this, you have the involvement, the presentation is necrotizing glomerulonephritis and pulmonary capillaritis. But coming to the last option, palpable cutaneous purpura is rare. Actually, in turn, you may be getting, okay, instead, it is one of the commonest finding, clinical finding, that is a palpable cutaneous purpura in microscopic polyangitis. So the wrong option here, that is the wrong clinical feature which they have mentioned here, and the correct answer is palpable cutaneous purpura is rare. Yes. Now let us solve the other MCQ. Buerger's disease involves artery, artery and vein, artery, vein and nerve, none of the above. So what is Buerger's disease? Buerger's disease is otherwise called as TAO, that is the thromboangitis obliterans. Thromboangitis obliterans. So it is nothing but a segmental thrombosing arthritis extending to the veins and nerves. Basically, it is a lesion involving the artery. Arthritis. What happens to the arthritis? It is a thrombosis will be the formation. Thrombosis formation will be in the arteries, and these thrombus will be in the form of a segmental involvement. Okay, so it will be involving the segment wise, and later what happens, this will be extending to the veins and nerves. So this arthritis, that the inflammation thrombosing arthritis will be extending to the veins and nerves. So you have the involvement of artery, vein and nerves. And you would have seen these cases, that is, it is common in the heavy smokers. Why it is common in the heavy smokers? Because the smoking causes endothelial toxicity. Okay, the toxins from the smoke damage the layers of the endothelium, which forms as a protective layer. You know, the endothelium, which is a protective layer. So what happened? The smoke damages the endothelium. You know that yesterday, that if your endothelium is damaged, you're getting a formation of a thrombus. So that thrombus is occurring because of the smoke. And that the interesting thing is, even it is common younger than the 35 years. And the commonest arteries which are affected in the Buerger's disease is tibial and radial arteries. Okay, the most common arteries which are involved in Buerger's disease is tibial and radial arteries. And usually the patient will be having vascular insufficiency leading on to ulcer and gangrene. The patient will be having ulcer and gangrene, and nerve involvement. Due to the nerve involvement, the pain will be at rest. Yes, I told you the involvement is not only involving the arteries but also to the veins and nerves. So the patient will be having pain even at rest. Okay, so the pain even at rest is characteristic of Buerger's disease. And the HLA sometimes can be asked. In Buerger's disease, you have to remember HLA-A9, HLA-B5, and other risk factors, increased risk of this thromboangitis obliterans. And interestingly, HLA-B12 is protective. Some may be asking why that smoker is not getting Buerger's, why this smoker may be asked getting that Buerger's. The answer lies here. Okay, it is because of the HLA composition. Okay, HLA-B12 is protective, whereas HLA-9 and HLA-B5 predisposes to thromboangitis obliterans. Discussed among all these things, now you will be able to solve this very easy question, that is a Buerger's disease involves all the ways three things, that is the artery, vein and nerve. Now let us move on to the other question. Firm body vegetations along the line of opposition of heart valves is present in NBTE, that is non-bacterial thrombotic endocarditis, bacterial endocarditis, rheumatic heart disease, Liebman-Sachs endocarditis. So they have asked, there is vegetation in the heart walls, and those vegetations are firm, warty vegetations, and they are present along the line of opposition. Such type of vegetation is seen in which conditions? So whatever the four conditions they have described, that is the non-bacterial thrombotic endocarditis and bacterial endocarditis or rheumatic heart disease or Liebman-Sachs endocarditis, all these four things will be having the vegetations. But there is a difference in the nature of the vegetation. Let us see what is this thing. Then solve this question. Liebman-Sachs endocarditis is associated with rheumatic heart disease, SLE, carcinoma, and none. Let us move on to what about the vegetations. That is, I told no, all these four diseases will be having that vegetations. So let us see the different types of vegetations in different heart diseases. In rheumatic heart disease, what happens? The vegetations will be small. Vegetations will be small, but firm, warty vegetations along the line of closure. So this is the line of closure, and you can see this is all the firm vegetation just along the line of the closure. So the small firm warty vegetations are seen in rheumatic heart disease. What happens in infective endocarditis? In infective endocarditis, the vegetations are little large, like cauliflower-like, and they are friable in nature. Yes, the vegetations are very high, very bigger in size, and they are friable in nature and can erode your chorda tendineae and your papillary muscles. Yes, infective endocarditis. Just remember, infective endocarditis, what will be the clinical features? The patient will be presenting with that embolic manifestations, no? Rot spot, Janway spots, or osler nodes, you would have heard, no? That splinter hemorrhages. These are all the embolic manifestation with which the patient with infective endocarditis can present. So, embolic manifestation if the patient is presenting, the vegetation should be very friable. Yes, yes. So, this infective endocarditis, you will be having that very large friable vegetations which can even erode the chorda tendineae and the papillary muscles. Now let us see what happens in non-bacterial thrombotic endocarditis. So here also you will be getting the vegetations along the line of closure. Yes, you are getting the vegetations along the line of closure. But in rheumatic heart disease, it is a very firm, small vegetations, warty vegetations. But your non-bacterial thrombotic endocarditis, the vegetations are a little bigger. Yes, little bigger along the line of closure. Yes, these such things you will be getting in non-bacterial thrombotic endocarditis. Okay, usually you will be getting in carcinomas. Okay, such non-bacterial thrombotic endocarditis you will be getting that in conditions like cancer. So non-bacterial, it is not a bacterial origin, it is a non-infective etiology like carcinomas. The last one is the LSC. LSC, just turn the letters, it becomes SLE. Yes. So LSE, just turn the letters, it turns into SLE. So LSE is nothing but Liebman-Sachs endocarditis, which is seen in SLE, that is systemic lupus erythematosus. Systemic lupus erythematosus. So now what is this vegetations? This is rheumatic. Is it rheumatic? Is it infective? So these are the large vegetations which erode. So this is infective endocarditis. Firm warty vegetations along the line of closure, rheumatic. And larger vegetations along the line of closure, this is non-bacterial thrombotic endocarditis. And in the both the sides, okay, that is what is special thing about this Liebman-Sachs endocarditis is the vegetations are present along the both the sides of the valves. Okay, both the surfaces of the valves you can get the vegetations. Okay, in Liebman-Sachs endocarditis. Yes. Now solve this question. Firm body vegetations along the line of opposition of the heart walls is present in rheumatic heart disease. Liebman-Sachs endocarditis, LSC, just turn the letters, it becomes SLE, systemic lupus erythematosus. Now let us solve this question. False statement about pyogenic granuloma is they are capillary hemangiomas which occur as a red pedunculated lesion on the skin and gingiva. They are caused by infection with pyogenic bacteria. They grow rapidly, bleeds and ulcerates easily. So these are all the four options. And let us see the other question. Granuloma gravidorum. Granuloma gravidorum is a type of juvenile hemangioma, cavernous hemangioma, pyogenic granuloma, cavernous lymphangioma. So clinically, what is this lesion? For solving these MCQs, let us learn about the basic things about these MCQs. Clinically, this is the pyogenic granuloma. So what is it, pyogenic granuloma? Pyogenic granuloma is nothing but the other name for capillary hemangioma. So in the capillary hemangioma, what you will be getting, you will be proliferating of the small capillary sized blood vessels. Okay. So pyogenic granuloma, it is the proliferation of the small capillary-like blood vessels, which constitutes this spindle cells. And you can see this small capillary proliferation, small capillary proliferation. Yes. And this pregnancy tumor, remember, very interesting finding, pregnancy tumor or granuloma gravidorum is the other name for pyogenic granuloma, especially if this pyogenic granuloma is seen in gingiva of the pregnant woman. Okay, sometimes in pregnant women, they'll be getting such capillary hemangioma in the gingiva, and it is a spontaneously regressing lesion. Okay, nothing to worry about this lesion. Spontaneously regress after the pregnancy. So pregnancy tumor, granuloma gravidorum. Actually, it is not a granuloma, it is a misnomer. Gravidorum because it is seen in a pregnancy. Pyogenic granuloma, that is also a misnomer. You see a granuloma, not they are not pyogenic. Okay, not pus forming or not neutrophils are there. Okay, so the false statement about this pyogenic granuloma, you know that now they are capillary hemangiomas which occur as a red pedunculated lesion on the skin and the gingiva. Yes, they grow rapidly, bleeds and ulcerates easily. As a complication, they bleeds and ulcerates easily. And I told it is a misnomer, pyogenic is a misnomer. So it is not caused by infection with pyogenic bacteria. So the answer here is caused by infection with pyogenic bacteria. Granuloma gravidorum is a type of, yes, you know, it is a pyogenic granuloma. Now let us solve some questions with the cardiomyopathies. All are true about hypertrophic obstructive cardiomyopathy, except, yes, the options are asymmetric septal hypertrophy, dilatation of atria, dilatation of ventricles, outflow obstruction. Outflow obstruction. So the question they have asked is, all are true about hypertrophic obstructive cardiomyopathy except. So for solving these MCQs, we have to know about the hypertrophic obstructive cardiomyopathy. So what happens here, there will be a septal hypertrophy, and you can see because of the septal hypertrophy, the ventricular cavity will be compressed. Okay, this is the interventricular septum. That hypertrophy will be occurring in the interventricular septum also. This interventricular septum will be getting hypertrophied and it will be compressing the ventricular cavity. See this. This bulged interventricular septum is compressing the interventricular chamber, and the ventricular chamber is converted into a banana-shaped chamber. Okay, this is also an MCQ. Banana-shaped ventricle cavity is seen in your hypertrophic cardiomyopathy. Okay, because the interventricular septum, okay, is hypertrophied and it is compressing the ventricular chamber, and you will be getting the dilatation of the atrium. Dilatation of the atrium. Okay, so this is the gross features of HOCM, that is hypertrophic obstructive cardiomyopathy. And the thing is, the option here is the dilatation of the ventricles, because there is a asymmetrical septal hypertrophy which will be occurring, and we have seen the dilatation of the atria, and obviously there is obstruction of the ventricular outflow. So there is ventricular outflow obstruction will be there, and dilatation of the ventricles is not seen. Instead, ventricles are getting compressed into a banana shaped chamber. Yes. Then let us solve this MCQ. Which ischemic dilated cardiomyopathy is called as broken heart syndrome? Which ischemic dilated cardiomyopathy is called as broken heart syndrome? The options they have given are peripartum cardiomyopathy, alcoholic cardiomyopathy, Takotsubo cardiomyopathy, spongiform cardiomyopathy. Yes. So let us have some basic thing. Dilated cardiomyopathy, all the ventricular chambers, all the chambers of the heart are dilated. Okay, so all the chambers are dilated. So, and what is this Takotsubo cardiomyopathy? It is actually called as a broken heart syndrome. What happens is, it is a left ventricular contractile dysfunction following a psychological stress. So what happens whenever there is a psychological stress, whenever there is an emotional outburst, so the more catecholamines are released from the body. So that excess catecholamines becomes a toxic, especially the cardiotoxic, which can damage the myocardial contraction, myocardium, causing the multifocal contraction bands. So what happens whenever there is an emotional or stress outbreak? You get the excess catecholamines released from the body, and these catecholamines are toxic to the myocardium. So these toxic myocardium will be forming a contraction band, and it will be progressing to dilated cardiomyopathy. So why it is called a Takotsubo? It is actually Takotsubo is an octopus trap used in Japan. So to trap the octopus, they will use a peculiar chamber trap like this thing. The chamber of the heart, the chamber of the left ventricle will also getting converted, will be dilated like that of this Takotsubo. That is the octopus trap used in Japan, used by Japan people. Hence, this cardiomyopathy is called as Takotsubo. And as this cardiomyopathy is associated with an emotional outbreak or broken heart syndrome or love failure syndrome. Okay, so this is the dilated type of dilated cardiomyopathy. Yes. So the answer here is Takotsubo cardiomyopathy. The next question. Cardiac myxoma commonly arises from. Cardiac myxoma commonly arises from. They have asked left ventricle, left atrium, right ventricle, and the right atrium. So they have given all the four chambers, and they are actually asking from where the cardiac myxoma arises. So let us see something about this cardiac myxoma. Actually, these myxomas are arising from the primitive pluripotent, multipotent mesenchymal cells. Actually, this is a tumor which arises from the mesenchymal cells, and sporadic. 90% of these myxomas are sporadic in nature. That they form here and there one and two tumors. Solitary lesions, myxomas are solitary lesions, and the familial origin, that is Carney syndrome. It is associated with Carney syndrome, which is a autosomal dominant disorder, and these myxomas will be having a mutations in GNAS1 gene and PRKARIA gene. Okay, PRKARIA gene and GNAS1 gene mutations associated with this Carney syndrome, and these patients will be having myxomas. And very important point to be noted here in myxomas is about 90% of the tumors arise in the atria with a left to right ratio of approximately 4:1. So to simplify this thing, myxomas are common in the left atrium. Okay, so most of the myxomas arise from the atrium, and that too from the left atrium. So myxomas arise from the left atrium. Okay, so histologically, you can see this somewhat like a myxoid background. You can see a jelly-like or myxoid background. And what you can see here is this type of stellate cells, that is the star-shaped cells. Like your neuroglial, no, you have this astrocytes. Okay, so similarly, those kind of stellate cells you can see in this myxoma. So the cardiac myxoma commonly arises from left atrium. Okay. So let us see some questions, some more questions on the respiratory system. Clara cells. Okay, Clara cells are seen in alveoli, bronchus, trachea, bronchiole. So they are asking where you will see the Clara cells. The other question is that which of the following is not a component of acinus? So they are given pulmonary lobule, respiratory bronchiole, alveolar duct, and alveolar sac. So to solve these two questions, let us have some basic about that respiratory tree. Okay, so all of you will be knowing that right and left bronchus, actually the trachea will be dividing into right and left bronchus, and you have these bronchioles. Bronchus will be further dividing into bronchioles, and which will be having divided into terminal bronchiole. Okay, the bronchioles will be dividing into a terminal bronchiole, and this terminal bronchiole will be further dividing into respiratory bronchiole. Respiratory bronchiole will be having this alveolar duct, then alveoli. Okay, then in between the alveoli, you have the interalveolar septum. Okay, interalveolar septum. So, what constitutes an acinus? Actually, acinus is nothing but it is the respiratory bronchiole, alveolar duct, and the alveoli. These three together are called as acinas. Very important, please remember. Okay, so bronchioles will be divided into terminal bronchiole, respiratory bronchiole, alveolar duct, alveoli, that is alveolar sac. The last three, that is the respiratory bronchiole, alveolar duct, and the alveolar sac, constitutes your acinas. Yes, and pulmonary lobules is nothing but 3 to 5 terminal bronchioles. 3 to 5 terminal bronchioles with their acini are called as lobules. So lobules is something a different concept and acinas is something different. So acinas means it is respiratory bronchiole, alveolar duct and alveolar sac. Lobules means it is 3 to 5 terminal lobules, bronchioles with their acini. Yes, these are called as pulmonary lobules. And this alveolar duct will be having lined by this simple squamous epithelium. Okay, so this alveolar sac will be communicating with each other via the interalveolar septum, via the pores of Kohn, P-O-R-E-S, pores of Kohn, K-O-H-N. Okay, so and you will be seeing this the bronchioles. Bronchioles will not have cartilage. Okay, very important point. Bronchus will be having the cartilage and bronchioles will not have the cartilage. Okay, and the maximum smooth muscle present thickness to the wall of the layer will be seen in terminal bronchioles, and your Clara cells also will be seen in terminal bronchioles. With this background knowledge, we'll be seeing this thing. Clara cells are seen in bronchioles. Okay, especially in the terminal bronchioles. Okay, which one of the following is not a component of acinus? It is pulmonary lobule. You know this, respiratory bronchioles, alveolar duct and alveolar sac constitutes the acinus, and pulmonary lobule is not a component of acinus because that is a different concept. Let us solve this question. A 44-year-old male presented with severe respiratory distress. On examination, he had pedal edema, bilateral crepitus on auscultation. He was admitted to the emergency department and expired 2 days of admission. Lung biopsy suggested the following. What is your diagnosis? Cytomegalovirus pneumonia, small cell carcinoma lung, tuberculosis and heart failure cells. And they have shown an histological picture. So what you can see in this picture, and before that we'll be seeing another MCQ. Pulmonary infarction and pulmonary edema is differentiated by heart failure cells, necrotizing alveolar sac, capillary congestion, pulmonary wedge pressure. Okay, pulmonary wedge pressure. So for solving these questions, let us have a background knowledge of these things. So what happens to the lung here? And what is the patient presenting with? The patient presented with severe respiratory distress. Okay, and pedal edema. Okay, the patient is in a signs of failure. Yes, bilateral crepitus on auscultation, pulmonary edema. Yes, bilateral creps will be there. So both pedal edema and bilateral crepitus on auscultation, pulmonary edema, and it is an acute event. Okay, say patient is going for a severe respiratory distress. And also the patient has had a expire. Okay, 2 days. And lung biopsy, you can see this is the alveoli. You can see this is the alveolar space. And you can see the alveolar space is and the alveolar separated by this alveolar septum. The in between this alveolar cavity is the alveolar septum. So in the alveolar septum, you are getting some inflammatory cells. And what is so striking here is you are getting a very large cells. Some cells with something they contain something like a reddish or brownish granules. You can see here these type of cells. Okay, in the alveoli and in the alveolar septum, you can get this large cells with that brown or reddish granules. Yes, we are having this in mind. So basically we are having a thing with these cells are called as heart failure cells. So what happens in the heart failure? So whenever there is a left heart failure, there will be congestion occurring in the lung parenchyma. So pulmonary edema occurs. So pulmonary edema occurs, and also there is a congestion of the lung. So congestion of the lung occurs, okay, in pulmonary edema, and the lung becomes getting enlarged, okay, the size of the lung becomes much more increased, and you will be getting what is so called as the series or a reddish color or reddish to brown appearance, okay. So this is called as brown induration of the lung. Yes, another image based question. Brown induration of the lung is usually seen in pulmonary edema. Why there is a pulmonary edema? Why there is a brown induration should occur in pulmonary edema? Pulmonary edema, as such, you know this, it is because of the left heart failure, sudden left heart failure it occurs. So more RBCs will be stagnated in the lung alveoli, lung capillaries, and in the alveolar capillaries, and in the lung parenchyma. So these RBCs will be liberating the, after they die, they will be liberating that hemosiderin. Yes, the RBCs after their death will be liberating the hemosiderin, and this hemosiderin pigment will be engulfed by the macrophages. Yes, you have alveolar macrophages lining your alveolar cavity, and these alveolar macrophages will be engulfing the hemosiderin pigment. Okay, so what happens? The whole lung is expanded. Yes, you have the fluid, that frothy material. That frothy material will be there accumulated in the lung parenchyma. So you have a indurated lung which appears brown in color, and in the histologically you can see what is so called as these cells. Okay, so if you carefully appreciate these questions, you can this picture, you can see these are all the heart failure cells. So heart failure cells are nothing but these are all the alveolar macrophages. Heart failure cells are nothing but these are all the alveolar macrophages which have engulfed the liberated RBC, that is a hemosiderin. So with this background knowledge, we'll try to solve this thing. So try to fit in the clinical features and pathological features which we have learned. So severe respiratory distress syndrome. So the male, 45-year-old male, severe respiratory distress syndrome. Obviously, there is a lung involvement. He'll be presenting with the respiratory distress syndrome. Pedal edema. Yes, pedal edema will be there because of the failure. Bilateral crepitus and auscultation, because pulmonary edema will be having this bilateral crepitus, and especially in this with this picture, it is because of this heart failure cells. Okay, it is the, remember, your brown induration of the lung. Okay. Pulmonary infarction and pulmonary edema is differentiated by, again, by the heart failure cells, whereas necrotizing alveolar sac or capillary congestion and pulmonary wedge pressure will not be a much more important or reliable finding to differentiate between these two. And biopsy proven that presence of heart failure cells is characteristically seen in pulmonary edema, which will differentiate it from pulmonary infarction. Yes. So now let us solve this question MCQ, and we'll end with the class. In the early stages of ARDS, acute respiratory distress syndrome, which of the following cells are affected? They have given you 4 options: endothelial cells, type 2 pneumocytes, Clara cells, and type 1 pneumocytes. So basically it is a case of ARDS. Okay, basically it is a case of ARDS, that is the acute respiratory distress syndrome. So what causes this ARDS? So anything can cause ARDS. It can be an infection, it can be a physical or injury, or it can be a chemical injury, and whether the irritants inhaled irritants can be the hematological conditions can also cause this. Infections like sepsis, pulmonary infections, okay, especially with virus, mycoplasma, pneumocystis carinii pneumonia, miliary tuberculosis, gastric aspiration, all these things can cause ARDS. And physical injury, that is a mechanical trauma, including the head injuries, pulmonary contusions, near drowning, fractures. Okay, you know that long bone fracture, in long bone fractures which happens in road traffic accidents can lead on to fat embolism, burns, ionizing radiation. All these things can cause ARDS. and oxygen toxicity, fire accidents, smoke, where there will be liberation of this irritant gases and chemicals. And chemical injury with heroin, ASA, that is acetyl salicylic acid, barbiturates overdose, paraquat can also cause ARDS. And remember transfusion. So all these things you have to keep in mind, because in the clinical scenario, they may be giving you any one of these things. And they may be able to try giving you some clinical features and try to fit those clinical features with this etiological agent. Yes, you have to that think of that ARDS. So transfusion associated lung injury, DIC, disseminated intravascular coagulation, pancreatitis, uremia, cardiopulmonary bypass surgery, hypersensitivity reaction, organ solvents, and some drugs also can cause. Snake bite also can cause ARDS. So what happens? What happens in the ARDS in the lung parenchyma? So mainly the damage is happening in the alveoli. Okay, whether it is an inhalation of a smoke or inhalation of a chemical agent, or it can be physical agent. So whatever the injury, mode of injury, it mainly affects the alveolus. Okay, so alveolus, what happens? The bronchial epithelium getting sloughed off. The bronchial epithelium will be getting sloughed off, and the type 1 pneumocytes, okay, type 1 pneumocytes will be going in for necrosis. So type 1 pneumocytes will be going in for necrosis, and you will be getting that more edema fluid will be entering the lung parenchyma, okay, in the alveoli. So that you will be having that frothy fluid in the alveolar cavities, okay. So the necrosed, because of the toxins, the epithelial cells will be going in for necrosis. So your body, that neutrophils will sense there is some injury is going on there. So neutrophils comes into the picture, and it will try to elaborate your chemical mediators like platelet activating factor, leukotrienes, or proteases. Okay, so all these things will be elaborated by neutrophils, which in turn come from the blood vessel, blood circulation. So neutrophils migrate into the from the alveolar capillaries. Okay, from the alveolar capillaries, they will be trying to migrate into the alveolus and liberate all these things. So what happens? These chemokines in further in turn damages the alveolus. Okay, so it is a vicious cycle. Okay, so the actually the injury or inflammation recruits the neutrophil. The neutrophils actually, by liberating the chemokines, will be resulting in a further damage, okay, by liberating these chemical mediators. Okay, so what happens? Simultaneously there will be a fibroblastic reaction. So the injury, whenever there is an injury, body tries to heal by itself. So you will be having a fibroblast or pro-collagen formation will be there. So that injury, that solving, that healing mechanism will also be happening side by side. So ultimately what you can get in the histology is the formation of, what is the arrow is pointed out? The arrow, what is pointed out? See this is the alveolus, and in the alveolus membrane, you will be seeing a deposition of pinkish, that is the eosinophilic material, which is deposited around this alveoli, and this material is called as hyaline membrane. Yes, these are all the hyaline membrane. In the image based questions, they can show you this image and ask to find tell the answer. These are all the hyaline membranes. Okay, so hyaline membranes are nothing but because of that vascular injury, liberation of the hyaline like material, you will be getting that membrane which is just covering the alveolus. See, if there is such membrane is just covering the alveolus, where will be the air exchange will be taking place? And this is the cause of the death. For the DIC also will be the aggravating all these features. Okay, so hyaline membrane formation is a characteristic finding in ARDS. Okay, so now coming to the R question. In the early stages of ARDS, which of the following cells are affected? They are given endothelial cells, type 2 pneumocytes, Clara cells, and type 1 pneumocytes. And here it is mainly the type 1 pneumocytes which has damaged in early stages of ARDS. As you can see from this picture, it is the all the toxins will be damaging the sloughed bronchial epithelium, and it is the type 1 cell, okay, that is the necrotic type 1 pneumocytes will be the initially causing all these damages. So this damage only further recruiting the neutrophils and causing furthermore damage. Okay, so the answer is type 1 pneumocytes. So I'll end today's session with this question. Thank you for your patient listening. If any queries or any this thing feedback, you are welcome to give your feedback. So thank you very much for your patient listening.
Yeah. Thank you, Dr. Vimal.
Yes, sir. Thank you, sir.
Thanks for the wonderful session. Okay, we'll catch up tomorrow.
Sure, sir. Thank you, sir.